Welcome back to the Deep Dive. Today, our goal is to really cut through the noise and give you, our informed learner, the critical, actionable knowledge you need for clinical practice. And we are jumping into one of the most high-stakes, rapidly changing environments in all of medicine, the labor and delivery suite. We've synthesized a practical manual to labor and delivery, second edition, edited by Shad Deering, MD.
That's right. And this isn't just a book report. Our goal here is to distill this manual into a kind of mental checklist, one that really prioritizes safety and speed.
Because things can change in an instant.
Exactly. L&D is all about pattern recognition and immediate action. We're breaking down the principles that let you pivot the second a routine labor becomes an emergency.
So let's start right there with the nature of this environment. The manual makes it so clear why L&D is just different.
Oh, it is.
They're caring for two patients at once, everything is in flux, and the potential for blood loss is just. It's faster than almost anywhere else in the hospital.
It is, and that means the rules for crisis management are different. The first, and maybe the most crucial, safety fundamental is specificity. You have to be specific when a crisis hits.
What do you mean by that?
Well, we've all seen it. When a hemorrhage starts or a patient has an eclamptic seizure, you can't just yell, "Get drugs," to a junior team member.
They might not know what to grab.
Exactly. The book says you have to be explicit. State the name, the dose, the route. Get methadone 0.2 milligram IM now. Or I need the vacuum and I need anesthesia in this room in 2 minutes. That precision removes all the guesswork.
That makes sense, and that kind of clarity extends to the provider too, right?
Yeah.
The manual makes a really strong point about asking for help.
It does. It says getting a second opinion is a sign of maturity, not weakness.
It's the ultimate patient protection mechanism.
Absolutely. The old culture of, thinking you're weak for asking for help, that's thankfully fading. In a field where things change on a dime, you need your colleagues. If you feel uneasy, you just call.
And training is evolving too. We're not in the see one, do one, teach one era anymore.
Thank goodness. Simulation practice is foundational now. Running scenarios, practicing on models. The data is clear. It improves outcomes in real crises.
But tying all of that together is the clinical mindset. The manual uses this phrase. It sounds dramatic, but it's so practical. Assume the worst and hope for the best.
I love that phrase.
So what does that look like in a real clinical scenario?
Okay, so it's about practicing defensively without scaring your patient. A pregnant patient comes in with a headache. Before you even think about tension or dehydration, your brain has to first assume it's severe preeclampsia.
Rule out the catastrophe first.
You have to. You rule out the life-threatening stuff with an exam and some basic labs, and only then do you move down the list. That initial assumption, assuming the worst, is what guides your triage.
Right. So once we have that mindset, we move to the physical assessment. Labor has 3 distinct stages. Can we just quickly run through those benchmarks?
Sure. Stage 1 is everything from the start of regular contractions until the cervix is fully dilated at 10 centimeters and 100% effaced. And we split that into a latent phase and an active phase.
Latent can be long and slow.
Very long. Stage 2 is the pushing stage from full dilation to the delivery of the baby. And stage 3 is just the delivery of the placenta.
And the main tool for tracking this is the digital cervical exam. But this is where judgment comes in immediately. There are 2 absolute contraindications.
Yes, 2 hard stops. The first is active, heavy vaginal bleeding. If you see blood, you stop. You have to rule out placenta previa first.
Where the placenta is covering the cervix.
Right, and you'll need an ultrasound for that, maybe even a transvaginal one. Because if you do a digital exam with a previa, you could cause a catastrophic hemorrhage.
Okay, so what's the second contraindication? It's a little more nuanced.
The second is preterm premature rupture of membranes, or PPROM, before 37 weeks. The issue here is infection. Digital exams introduce bacteria, and that can lead to, chorioamnionitis, sepsis. It's a huge risk.
So what do you do instead?
You use a sterile speculum exam. You can visualize the cervix and confirm the rupture without increasing that infection risk.
Got it. So once we know it's safe to do the exam, we're checking fetal station. What's the landmark we're using, and what's the big risk associated with it?
The landmark is the maternal estrolal spines. When the baby's head is right at those spines, that's 0 station. The scale goes from -5, which is high, to +5, which is crowning.
And the critical risk.
It's all about that -2 station line. If you're thinking about an amniotomy, artificially rupturing the membranes, and the head is higher than -2 station, you are seriously risking an umbilical cord prolapse.
Where the cord slips out ahead of the head.
Which cuts off blood flow. It turns a routine procedure into a crash C-section in seconds. So station is a core safety check.
And we also need to know the fetal head position. This means feeling for the sutures. Why is it so important to know if the baby is OA versus, say, OP?
Because it completely changes how you manage the second stage. You feel for the sagittal suture and then the fontanelles, the diamond-shaped anterior one and the smaller triangular posterior one. Finding the posterior one tells you where the occiput is.
And OA, occiput anterior, is the ideal position.
It is. A persistent OP, or occiput posterior position, can make labor much longer and really increases the risk of needing a C-section.
And just a quick reminder on dating. If a first trimester ultrasound differs from the LMP by more than, 5 to 7 days?
You go with the ultrasound. The ultrasound becomes the gold standard for the EDD, the estimated date of delivery.
Okay, let's shift to evaluating the membranes and triage. There are 4 parameters we need to check to confirm a rupture.
Right. It's a 4-part check. First is pooling. Do you see a pool of fluid in the vagina? Second, can you see fluid coming from the os when the patient coughs? The Valsalva maneuver.
Then we get to the chemical and microscopic tests.
Exactly. Third is the nitrazine test. The paper turns blue if the pH is over 6.5, which suggests amniotic fluid, but you have to watch for false positives from blood or semen.
And the 4th and most definitive.
That's the Ferning test. You put a sample on a slide, let it dry, and amniotic fluid crystallizes in this beautiful fern-like pattern. That's your confirmation.
And before we move on, let's just hammer this one more time. The rule for AROM, artificial rupture, is an absolute contraindication if the head is high.
Above -2 station.
Or if the presentation is in vertex.
Hard stops, absolutely.
Okay, fetal surveillance. The main non-invasive tool is the non-stress test, the NST. What makes an NST reactive after 32 weeks?
A reactive NST, which is what you want to see, needs at least 2 accelerations in a 20-minute window. An acceleration is the fetal heart rate jumping 15 beats above baseline for at least 15 seconds.
And if it's non-reactive?
First step is usually vibroacoustic stimulation. It's basically a little buzzer on the abdomen to try and wake the baby up.
And what about the contraction stress test, or CST? What defines a positive or concerning test?
A CST is positive if you see late decelerations. That's drops in the heart rate after the peak of a contraction following more than half of the contractions. It's a big red flag for uteroplacental insufficiency.
Which brings us to interpreting the fetal heart rate tracing itself, using that 3-tier system. Category 1 is normal, Category 3 is ominous.
Right, and Category 3 means you're moving towards delivery fast, but Category 2, that's the gray area. That's where most of the work happens.
So it's not just everything in between.
No, it's an indeterminate tracing. It's not clearly normal, but it's not yet clearly pathological. And the key is you cannot just passively watch a Category 2 tracing. You have to be actively managing it.
So if you have a Category 2 that's worsening, where you see a Category 3, what are the immediate steps for intrauterine resuscitation?
You have a checklist. Step 1, stop the oxytocin if it's running. Step 2, change the maternal position, usually to her left side. Step 3, give supplemental oxygen. Step 4, check her blood pressure and correct any hypotension.
And Step 5?
Always a quick vaginal exam to make sure there's not a cord prolapse.
And what if the uterus is contracting too much, what we call hyperstimulation?
That's when you give terbutaline. A small subcutaneous dose can relax the uterus almost immediately and take the stress off the fetus. Doing those steps quickly and systematically can often get you back to a Category 1.
All right, let's talk about operative interventions, starting with the external cephalic version, or ECV. This is to flip a breech baby.
Right, to avoid a C-section. This is usually done around 37 weeks, but the safety setup is non-negotiable. First, you have to relax the uterus with a tocolytic, usually terbutaline.
And the setting is critical.
Absolutely. This has to be done in an environment where you can do a crash C-section. That means an OR, with anesthesia scrubbed and ready to go. You're checking the fetal heart rate every 2 minutes, and if you see any distress, you stop and deliver.
Okay, moving to operative vaginal delivery forceps, or a vacuum, there are 5 essential criteria that have to be met.
Yes. The 5 rules of engagement. 1, the cervix must be completely dilated. 2, membranes ruptured. 3, you have to know the exact fetal head position. 4, the pelvis has to be adequate. And 5, the head has to be low.
How low?
At +2 station or lower. This is what defines it as a low or outlet delivery. If you can't meet all 5 of those, you don't proceed.
And for the vacuum specifically, there's a hard contraindication for prematurity.
Yes. You never use a vacuum on a fetus younger than 34 weeks. The risk of intraventricular hemorrhage is just too high. And of course, you wouldn't use it if there's a known fetal bleeding disorder.
Finally, C-sections. The rate in the U.S. is high, around 32%. The type of uterine incision has huge long-term implications.
It really does. It affects the patient's entire reproductive future. The standard is the low transverse incision. It heals well, and it usually allows for a trial of labor after cesarean, or TLAC, in the future.
But some incisions mandate a repeat C-section.
They do. A classical incision, which is a vertical cut high on the fundus, or a T or J-shaped incision. These mean all future babies must be delivered by C-section. The risk of uterine rupture and a subsequent labor is just too high, up to 9%. That has to be documented perfectly.
And in a true emergency, a crash C-section, the choice of anesthesia changes dramatically.
Time is everything. If you need that baby out in 5 minutes, you're likely moving to general anesthesia. And while it's much faster, the maternal risk is significantly higher than with regional anesthesia. It
Right.
really underlines the gravity of the situation.
Let's turn to postpartum emergencies, starting with the big one, postpartum hemorrhage, PPH.
Right. And blood loss is always underestimated. The definition is an EBL over 1,000 millil, or any blood loss causing signs of hypovolemia. But the key is to act before you think you've hit 1,000 millil.
So you suspect PPH. What's the immediate algorithmic response?
First, call for help. Activate your hospital's hemorrhage protocol. At the same time, get 2 large bore IVs going, start fluids, monitor vitals, and start looking for the cause using the 4 Ts.
Cone, trauma, tissue, and thrombin.
And uterine adenine is the cause in, 80% of cases? It's by far the most common.
So to treat adenine, we use uterotonics, but we have to know the contraindications cold.
Absolutely. First line is always oxytocin. Then you have methadone, which is a powerful vasoconstrictor. It's absolutely contraindicated in patients with hypertension or preeclampsia.
Because it could cause a stroke.
A hypertensive crisis, a stroke, exactly. Third is hemabate, prostaglandin. Its major contraindication is asthma because it can cause severe bronchospasm.
And the fourth one.
Misoprostol, often given rectally, it has the fewest contraindications, which makes it a really valuable backup when other drugs are too risky.
One of the most frightening emergencies is uterine inversion.
Catastrophic, and it's often caused by pulling too hard on the umbilical cord.
So it's preventable.
Largely, yes. The technique is to apply gentle traction on the cord with one hand while simultaneously applying firm suprapubic pressure with the other hand. This stabilizes the fundus and keeps it from turning inside out.
And finally, let's touch on laceration repair. We need to be meticulous, especially with the deeper tears.
We do. Third and fourth degree tears, which involve the anal sphincter and rectal mucosa, have to be identified and repaired perfectly. A missed or poorly repaired fourth degree tear can lead to devastating long-term problems for the patient, like incontinence or a rectovaginal fistula.
And to close the loop, the APGAR score. Assigned at 1 in 5 minutes, but it's not a long-term predictor.
No, and the most important life-saving principle here is this. You never wait for the 1-minute APGAR score to start resuscitation. If the baby is born limp, apneic, you act immediately. The clock starts at birth.
So what we've really distilled here is the essential framework for clinical action. It's about meticulous assessment and decisive reaction.
That's the core of it. This framework prepares you for everything from a normal labor to the most critical emergencies. It makes you a safer, more confident provider.
Okay, so to solidify this, here's a review question for you. Let's say your patient's fetal heart rate tracing is showing minimal variability, recurrent late decelerations, and the baseline is down to 100 BPM. What is the very first thing you do regarding any running medications and why?
Okay, so that's a category 3 tracing. It's ominous. The very first action you take is to immediately stop any running oxytocin.
Why is that the first step?
Because the oxytocin is causing contractions, which are stressing the baby and likely causing that uteroplacental insufficiency. Stopping it is the fastest way to reduce uterine activity and give the fetus a chance to recover while you prepare for other interventions. It's step 1 in intrauterine resuscitation.
Knowing those immediate actions, those contraindications, that's what makes the difference. The immense responsibility of L&D is met with preparation, and that ensures the best outcomes for both of your patients. Thank you for joining us for this deep dive.